All right, let's dive right in. Today we're tackling Dupuytren's disease, and we're going to really dissect this topic. It's a must-know, especially for those gearing up for surgical board exams. Consider this your cheat sheet to absolutely crushing it on this topic.
Couldn't agree more. Dupuytren's, it's that hand condition where the tissue just under the skin of the palm and fingers, it starts to thicken, tighten up. You get those lumps, those tough bands forming, and eventually it can really pull the fingers into a bent position. Can't straighten them out.
Right, yeah, those contractures.
Exactly. Now, we can thank Guillaume Dupuytren. He, way back in 1831, really clarified this condition for us. But honestly, even today, understanding all those little details, those nuances, it's still crucial, not just for the exams, but obviously for real-world practice, too.
Absolutely. So let's cut to the chase. What are the must-know high-yield points about Dupuytren's?
So first off, who does it typically affect? Well, picture this. Your classic Northern European white male. That's your prime demographic for Dupuytren's. See it way less often in Black populations. Interesting fact. You see it in Japan, but practically unheard of in other parts of Asia.
Huh, that's interesting. Okay, so mainly men, Northern European descent.
Yeah. And then age-wise, definitely see it more in men, at least until they hit those later years, 70, 80, around there. After that, the rates kind of even out a bit. But overall, the older you get, the higher your chances of having to deal with Dupuytren's.
Makes sense. Now, what about genetics? Does it run in families?
There's definitely evidence pointing to an autosomal dominant inheritance pattern. So yeah, it can be passed down through families. But here's the catch. It's got this thing called variable penetrance and expression. What that means is not everyone who inherits the gene will actually get the disease. And even if they do, the severity can be completely different, even among close family members.
Oh, so you can have the gene but not show any signs.
Exactly. And one more thing, it tends to be bilateral. Both hands are usually affected. Now, in terms of the specific fingers, the ring finger, the small finger, and the long finger, those are your usual suspects. They get hit the most. Thumb and index finger, not so much.
So you also mentioned Dupuytren's diathesis. What exactly is that?
Great question. So diathesis, it's like the more intense, aggressive version of the disease. Think of it like this. Earlier onset, it hits you younger. It progresses faster, really takes off. And once you treat it, it's more likely to come back and bite you again. Higher recurrence rate.
Okay, so it's more severe, it's faster, and it's more likely to come back.
Got it. So how do we know if someone has this diathesis type?
There are some key signs. Being male, younger age when it starts, both hands involved, family history of Dupuytren's, and if you see those knuckle pads, the Garrod's pads, if you're seeing those, that's a big red flag. Knowing this early on, it really helps us tailor the treatment plan and, be realistic with the patient about what they can expect. Right. Setting those expectations is huge. Okay, so we've talked about demographics, inheritance, the more aggressive form. Are there any other conditions that tend to show up alongside Dupuytren's? Like if you see one, you might see the other.
Yep, there are a few. Peyronie's disease, that's one, affects the penis. Then there's Lederho's disease, which affects the soles of the feet. And then adhesive capsulitis, better known as frozen shoulder. It's good to keep these associations in mind, just adds another layer to your patient evaluation.
All right, so we've got a good grasp of who gets it and the related conditions. But what causes Dupuytren's in the first place?
That's the million-dollar question, isn't it? It's frustrating, but the truth is we still haven't nailed down a single definitive cause. We see a lot of associations, things that pop up alongside Dupuytren's, but proving a direct cause and effect relationship, that's a different story.
Right, correlation doesn't always equal causation.
Exactly. And that's what makes this so tricky. It's likely multifactorial, a bunch of different things playing a role.
Okay, so let's break down some of these associations then. What about alcohol? Is there a strong link there?
So we do see a higher incidence of Dupuytren's in people who drink alcohol, that's for sure. And there's a theory floating around that maybe it's got something to do with liver function, but honestly, the jury's still out on that one. There's no rock-solid proof that alcohol directly causes Dupuytren's. It's an association, not necessarily a cause.
Makes sense. What about jobs that involve a lot of manual labor, heavy use of the hands? Does that play a role?
You'd think so, right? With all those physical changes in the hand, but surprisingly, a strong connection with manual labor, it just hasn't been consistently proven. There's this idea that maybe it's repeated microtrauma, small injuries over time that trigger those tissue changes, but the research, it just doesn't fully back that up.
Interesting. So not as straightforward as it seems. Okay, now what about smoking? I feel like that comes up a lot.
Smoking is definitely a player. There's good evidence for that. It seems to be involved both in the development of Dupuytren's and in how fast it progresses. And, that link we talked about with alcohol, it's possible that smoking habits could be part of that equation for some people.
Okay, so smoking is definitely a risk factor. Now, switching gears to medical conditions, what about diabetes and epilepsy? Are those connected to Dupuytren's?
So we do see Dupuytren's more often in people with diabetes, that's true. But it's not a slam dunk. Some studies haven't found that same link. The epilepsy connection is even less clear. Some researchers think certain anticonvulsant medications might be involved, but again, more research is needed. It's another one of those associations that we need to keep in mind, but it doesn't automatically mean one causes the other.
Right, right. So we don't know exactly what causes it, but we do know some things about the changes happening in the hand itself.
For sure. That fibrous tissue, the fascia, it gets all messed up in Dupuytren's. The big thing is the diseased fascia has way more type 3 collagen compared to healthy fascia.
Okay, so the composition of the tissue changes.
Yeah.
And how does the disease actually progress?
Think of it in 3 stages. First, you get the nodules, those bumps. In this stage, it's all about high type 3 collagen, the tissue is disorganized, the cells are super active, and you've got those myofibroblasts running around. Those are the cells that contract and pull things tight. Then you move into stage 2, cords start to form, but the fingers aren't bent yet, no contracture. Now the cells are calming down a bit, and the collagen fibers start lining up, getting more organized. Finally, you hit stage 3, mature cords, and that's when you get the finger contractures. They can't straighten out anymore. By this point, the collagen is super organized, and there are barely any cells left.
Wow, so it's like a whole cascade of events.
Hmm.
So we need to be able to tell the difference between normal structures in the hand and these abnormal cords, right?
Exactly. It's not just any old fascia that causes the problem. Specific structures get thick and form those pathological cords. You've got the spiral bands, lateral digital sheets, natatory ligaments, tendinous bands, and Grayson's ligaments. Important note here, Cleland's ligaments. Those stay out of the fight.
So Cleland's ligaments, those are off the hook. Got it. And each of these specific structures, when they get diseased, that's what leads to the different types of contractures, right?
Absolutely. Each band corresponds to a specific cord. For the MP joint, the one at the base of the finger, the main culprits are the protendinous cord or the protendinous part of that spiral cord.
Okay, so tendinous cord for the MP joint. What about the PIP joint, the middle joint in the finger? Those contractures seem trickier.
Yeah, the PIP joint, you've got the central, spiral, and lateral cords all ganging up on it. Now, the spiral cord, that one's a real troublemaker. It's made up of the protendinous band, the spiral band itself, the lateral sheet, and Grayson's ligament. And here's the problem. When that spiral cord forms, it can actually push the neurovascular bundle, that's the nerve and artery, towards the middle and the surface of the finger.
Oh, so it's not just pulling, it's also displacing important structures.
Right. And then you've got the central cord, which is basically just a continuation of those protendinous fibers from the palm right into the finger. And lastly, the lateral cord, that one starts at the natatory ligament and goes into the lateral digital sheet.
Okay, that's a lot of anatomy.
Yeah.
So what about contractures in the web space, between the fingers or at the DIP joint, the tip of the finger?
Web space, that's usually the natatory cord's fault. And for the DIP joint, you're looking at the renovascular cord.
Okay, so now that we've covered the anatomy and the progression, let's talk treatment. When do we actually intervene? What are the general guidelines?
First and foremost, gotta be upfront with the patient. We can manage Dupuytren's, we can improve things, but we can't cure it. And it often comes back, recurrence is a real thing. Setting those realistic expectations from the get-go is so important.
Absolutely. So when do we say, all right, let's do something about this?
Generally speaking, when those contractures are causing a real problem, if the patient's losing hand function, struggling with everyday tasks, or having trouble with hygiene, that's when we start thinking about intervention.
Okay, so function and hygiene, those are the biggies. Are the indications different for MP joint versus PIP joint contractures?
They are. MP joint, it tends to respond better to treatment, generally speaking. So if there's a significant contracture, that's usually a green light for intervention. We sometimes talk about specific angles, but honestly, it really boils down to how much it's affecting the patient's life. Now, the PIP joint, that's a tougher nut to crack. It's way more prone to stiffness, doesn't always regain full extension. So we tend to intervene earlier with PIP joint contractures. Even a small contracture, if it's causing problems, we'll consider treatment.
So, earlier intervention for PIP joint contractures. Got it. What about rapidly progressing cases?
Yeah, those two. If it's really taking off, we might want to jump in sooner rather than later.
Makes sense. Is there any kind of quick test we can do, like in the clinic, to see if treatment might be needed?
There's a little trick called Houston's tabletop test. Basically, ask the patient to lay their hand flat on the table. If they can't do it, if one or more fingers can't touch the surface, that's a good sign that the contracture is significant enough to consider treatment.
I like it. Nice and simple. Okay, so when do we not intervene?
A few scenarios. If it's a mild MP joint contracture and it's not bothering the patient, no functional limitations, we usually leave it alone. Just nodules or cords without any contracture, no need to jump the gun there either. And of course, if the patient has unrealistic expectations about what treatment can achieve, gotta have that conversation, manage those expectations.
Right, that makes sense. Okay, so let's talk about the preoperative assessment. We know it's primarily a clinical diagnosis, so what are we looking for?
Exactly. We're not usually ordering a bunch of tests for this one. The history is super important. We want to know how long they've had it, how fast it's progressed, what specific activities are difficult, any family history, and any other medical conditions they have.
So really getting the full picture.
Absolutely. Then, of course, you have the physical exam. We're looking at the hand, feeling it, trying to identify where those cords are, what type they are, if there are any nodules, if the skin is tight or tethered.
Anything else we're looking for on exam?
Yeah, a couple more things. We check for something called a Boutonniere's deformity. That can sometimes mean the outcome after we release the contracture might not be as good. We also want to figure out how much of a PIP joint contracture is due to the Dupuytrens cord itself and how much is from stiffness in the joint itself. A little trick for that is to passively bend the MP joint, see how much that improves the PIP joint. And of course, we measure those contractures, get those angles. And last but not least, we check for those other conditions we talked about, like the Garrod's pads.
Okay, so a thorough exam is key. Now let's get into treatment options. We know there are non-operative and surgical approaches. Starting with non-operative, what are the main options there?
So we've got a bunch of non-operative treatments, but here's the thing. None of them have really been shown to completely stop or reverse the disease. They're more about managing symptoms and slowing things down. Some examples are radiation therapy, ultrasound, some medications like colchicine and interferon, corticosteroid injections. Those can help with pain in those isolated nodules, but they don't affect the overall disease.
Okay, so those are more for symptom relief. Now, what about collagenase injections? Those seem to be gaining popularity. What's the deal with those?
Yeah, collagenase injections are becoming more common. They use this enzyme, collagenase Clostridium histolyticum, and you inject it right into the Dupuytren's cord. It basically breaks down the collagen, weakens the cord. Then about a day later, the doctor will manipulate the finger, try to break the cord. After that, it's usually splinting at night for a few months. You don't always need formal hand therapy.
So it's like a two-step process: injection, then manipulation.
Exactly. Now, there are some downsides. You can only treat one cord at a time, and if you need multiple injections, you have to space them out. And there are potential complications. Some are common, like pain, swelling, bruising at the injection site. You can also get skin tears during the manipulation. And rarely, but it can happen, a tendon can rupture.
Okay, so it's not without risks.
Right. And it works better for MP joints than PIP joints. And the big thing is the contracture can come back, recurrence is still a big concern. And collagenase, it's only for adults who have a palpable cord and a contracture. It's not for everyone.
So specific indications for collagenase. Got it. Now, what about needle fasciotomy? How does that work?
Needle fasciotomy, or percutaneous aponeurotomy, it's basically using a needle to break up the cord. You insert the needle through the skin and make multiple cuts in the cord. Then you straighten the finger to help break it up even more. After that, it's usually night splinting, similar to collagenase.
So another minimally invasive option.
Yep. One good thing is you can often treat multiple cords at the same time. But there are risks. You can get skin tears, you can injure nerves or tendons, especially with those tricky spiral cords. It's pretty effective for MP joints, but not so much for PIP joints. And recurrence rates, they tend to be higher compared to surgery.
Okay, so higher recurrence with needle fasciotomy. Got it. Let's move on to surgical treatments. What are the different options there?
All right, so surgically, we've got a few approaches. There's open fasciotomy, where you just cut the cord without removing any tissue. It's less invasive initially, but the contracture is more likely to come back. Then there's limited fasciectomy, which is the most common approach. You remove the obviously diseased fascia, but try to preserve as much normal tissue as possible. There's a variation called the McCash technique, where you make transverse incisions and leave them open to heal on their own.
Oh, so those wounds are left open.
Yep, in the McCash technique. It helps to reduce the risk of hematoma.
Interesting. Are there more aggressive surgical options?
There are. Radical fasciectomy, that's where you remove a lot more fascia, even some that looks normal, but studies haven't shown that it really reduces recurrence, and it has a higher risk of complications. Then you have dermatofasciectomy, that's the most aggressive. You remove the fascia and the skin on top of it. It's usually for really severe cases or recurrent cases, and you often need a skin graft or let it heal by secondary intention.
Okay, so those are reserved for more complex situations. What about the incisions? Are there different types?
Yeah, we've got a few options there. Longitudinal incisions, those go along the length of the cords, and we often use Z-plasties to help lengthen the skin. Transverse incisions are common in the palm, especially for the McCash technique. And then there's the Brunner incision. It's kind of a zigzag pattern, gives you some skin lengthening too, but can be a little riskier in terms of blood supply.
So different incisions for different situations. Now, what about those PIP joint contractures? You mentioned they can be tough to fix.
Yeah, they are. If the PIP joint is still stiff after we remove all the bad fascia, we might have to release the joint capsule and ligaments. It's a stepwise approach. Start with the check rein ligaments, then the volar capsule, and then the collateral ligaments if needed. But the latest research suggests that doing a super aggressive release, it may not actually give you much benefit and could even increase the risk of problems.
Interesting. So what are some of the reasons a finger might not fully straighten out even after surgery?
A few things can contribute to that. Number one, maybe we didn't get all the diseased fascia. If there's stiffness in the joint itself, especially the PIP joint, that can limit how much it straightens. Also, if that central slip of the extensor tendon is weak or damaged, that can be a problem. And of course, if the patient doesn't do their hand therapy, that can really hinder the outcome. And in some severe, long-standing cases, the blood vessels in the finger can actually get contracted, which limits how much we can straighten it during surgery.
Okay, so multiple factors can play a role. What about postoperative care? What's typically involved?
So after surgery, the usual routine is dressing changes every few days. Sutures come out around 2 to 3 weeks. If we left any incisions open, then it's daily dressing changes. Splinting is a big one, super important. We usually put a splint on right after surgery, often a plaster splint at first, then switch to a custom-made thermoplastic splint at the first follow-up. The splint keeps the finger straight, and they'll usually wear it at night for up to 3 months, depends on how bad the contracture was.
And what if we couldn't fully straighten the finger during surgery?
If we had to be cautious because of blood supply, we might do serial splinting, gradually increasing the extension over time. There are also dynamic splints that can be helpful. In early hand therapy, that's crucial. Got to get them moving those fingers as soon as possible.
Right, so splinting and hand therapy, those are key. Now, what about complications? What are some things that can go wrong?
One common one is a hematoma that's bleeding under the skin. Open healing techniques and careful hemostasis during surgery, those can help reduce that risk. We can also injure the digital nerves or arteries, especially with those spiral cords where the anatomy is distorted. Got to be really meticulous with our technique. Start the dissection in the palm, know the anatomy like the back of our hand. And then there's skin flap necrosis. That's when the skin dies because of poor blood supply. Careful incision planning, avoiding tension on the skin, that's how we prevent that.
So those are some of the surgical complications. Any other complications to be aware of?
Yeah, one more that can be a real pain. It's called Dupuytren's flare reaction. It's basically excessive swelling, redness, pain, stiffness, all that fun stuff, and it happens after surgery. It can actually look like complex regional pain syndrome sometimes. If it happens, early aggressive hand therapy is key. We might even consider steroids or nerve blocks in severe cases.
All right, so a lot of potential complications to keep in mind. What about outcomes overall?
Generally, surgery works pretty well to restore motion, but those PIP joint contractures, they're the tricky ones. Even if we fix them, they don't always stay fixed. And recurrence, that's a problem no matter what treatment you choose. The rates vary a lot, but it's always a concern.
So we can improve things, but it's not always a permanent fix.
Right. Okay, so let's recap the key takeaways here. Dupuytren's, it mostly affects older men of Northern European descent. Ring and small fingers, those are the ones that get it the most. We see it more often with alcohol use, smoking, diabetes, but the exact causes are still a mystery. Genetics definitely plays a role. The aggressive form, Dupuytren's diathesis, got to know how to recognize that.
Okay, what else?
Cleland's ligament, it's always spared. The neurovascular bundle, especially with those spiral cords, remember, it can get pushed around. For MP joint contractures, we think about surgery if it's causing functional problems. For PIP joint contractures, any contracture is usually enough to consider intervention. And collagenase injections, remember, those are an option for adults with palpable cords and contractures, specific indications for that one.
Perfect. This has been a fantastic review, really hit all the high-yield points. It's clear that treating Dupuytren's effectively requires more than just knowing the techniques. It's understanding the disease itself, how it behaves, and what the limitations of each treatment are.
Couldn't agree more. Knowing the anatomy, the disease process, the indications, the complications, that's what allows us to make informed decisions and have those honest conversations with our patients.
Exactly. So to wrap things up, here's a final thought for everyone. We know recurrence is a big issue with Dupuytren's. So when a patient comes to us considering treatment, what are the absolute must-have conversations, the things we absolutely need to discuss with them? That's something to ponder.
And that's a wrap for today's deep dive. Thanks for joining us.